right. Yep. So you spelled it right. Peritonitis. That's the biggest complication of peritoneal dialysis. Don't ever forget that. Anybody that's on peritoneal dialysis the rest of your life, always be monitoring for signs of infection. White blood cell count going up, the patient running a fever. How else would we know that they have an infection in their abdomen? What's the fluid going to look like that when we drain it back out into the bag, what's it going to look like? Yep. Cloudy. It's going to look infected. It's going to have pus in it. It's going to have cloudiness in it. It's not going to be clear. What color should it be? Clear straw color, like a light yellow color when it comes back out. What's one important thing? If I put 1 liter of fluid into somebody's abdomen, how much do I want to get back out? One liter of fluid back out. Perfect. Perfect. What could I do if I don't get enough out? What would I do that's easy to do with the patient that helps drain the fluid that's in their abdomen? I could give them diuretics. What else can I do even before I give them medication that you think would help drain? Yep, reposition the patient. And lots of times that's all you need to do. So that would be your first choice on NCLEX is reposition the patient, move the patient. Why? Because if that fluid's in their abdomen and it's kind of sitting in their belly, what if they're obese? What if they're laying on their left side? What if they're on their right side? What if they're laying on their back? Anything you can do, reposition the patient and then keep draining the fluid, and you'll see that it should come back out. Everybody keep your cameras on so I can see it. So again, reposition the patient, turn them on their side, turn them on their left side, turn them on the right side, go back and forth with them to try to get that fluid out from inside their abdomen. Because remember, whatever we put in, we should be getting back out. It should be clear. It should be a light yellow. It shouldn't have cloudiness. It shouldn't have signs of infection. What's one thing about a patient that we have to assess first? This could be your NCLEX question. Before they go home on peritoneal dialysis, what do we want to know about that patient? Put it in the chat. Yep, keep going. Yep, we want to know their electrolytes. Yep, that's important. We want to know their weight. But what about the dialysis itself? The instructions of the dialysis, I guess that's what I'm looking for. What about the fact that we're now going to send you home and you're going to get peritoneal dialysis at home? What would I want to know first? If that patient doesn't have anybody living with them. That's a hint. Yeah, their education. Are they able to even perfect their cognitive level? Exactly. Are they even able to understand peritoneal dialysis? So again, we have to recognize it doesn't work for everybody. If somebody's going home, they're 60 years old and their house is a mess and people live like that and they don't have anybody living there with them, or they've had a stroke and they can't use both of their arms, we have to think about, is this person going to be a good candidate for peritoneal dialysis? Are they even going to understand how to do it? And physically, are they able to do it? So cognitive level is important. So I just want us to recognize there's 2 different types of dialysis. What are some of our complications? This is what's going to be on the renal test, which we'll probably do like 2 weeks from now. Moving on, we talked about complications. What about our blood sugar when we get peritoneal dialysis? What do we say, or both? What do we say about a blood sugar? Does it go up or does it go down? Well, you got a 50-50 chance. I see some ups and I see some downs. What actually happens when you get peritoneal dialysis and hemo sometimes is the blood sugar goes up because it has a lot of sugar in the solution that we're using for dialysis. So some of that sugar is absorbed into the patient's vascular system and their blood sugar goes up. So expect when somebody gets dialysis, particularly peritoneal, because there's a lot of sugar, it's hypertonic, remember? In order for it to be hypertonic, it has a higher concentration of sodium, a higher concentration of sugars in it. It removes fluid, but the sugar in the solution itself makes the patient's blood sugar go up a little bit. So after dialysis, expect that you're going to see the patient's blood sugar go up a little bit usually, and maybe we have to give them a little bit of extra insulin. Okay, so that's good. Hemodialysis and peritoneal we talked about yesterday. We talked about UTIs yesterday. put in the chat something that's a risk factor for UTIs. Give me a couple different things that you think put people at higher risk for developing a urinary infection. Somehow I knew that the one answer was going to pop up from a lot of people. Okay. Okay, your age, yep, age being older or younger females. Why younger females? What do we say about their urethra? It's shorter, yep. So here's our risk factors for UTIs, yep, like from front to back, their age, sexually active, postmenopausal women, females are higher risk just because they're a female and not a male, for obvious reasons. Yep. So here's our risk factors for UTI, and this is what we kind of ended on yesterday, and we were talking about polynephritis. Female patients, younger and older patients, particularly younger, and particularly older, I mean, sexually active people, postmenopausal women, females because of short urethra, people that don't wipe from front to back, wiping from back to front will put us at risk for UTIs because we introduce E. coli into our urethra. Patients that are diabetic, higher risk for UTI. Patients that have an enlarged prostate, higher risk for UTI. What about if your story says your patient has urinary retention and they're actually retaining urine in their bladder, higher risk for UTI? That's why you're always going to pick toilet the patient, take them to the bathroom, frequently have them empty their bladder so that they don't get a UTI. What's the one thing that we do? And I think Mercy just typed it in there. What do we do as professionals? We used to put them in all the time, Foley catheters. Always pick that as one of the reasons why people are high risk. And that's one of the main nosocomial infections. Remember that word that we learned way back in the beginning is UTIs because we put Foley catheters in everybody. So what's going to be your answer on NCLEX? Get that Foley catheter out. Get it out as soon as possible. Have the patient voiding on their own, wiping from front to back, washing their hands. Anything that we can do to minimize the risk for UTIs. Okay, what is, we talked about a urinary tract infection. What part of the urinary system could that affect? Your urethra, your bladder, your ureter. That's what a UTI is. What if somebody has an infection of their bladder? What's that called? Type it in the chat. It's the word we're looking for. Yep, cystitis. Yep, there it is. Cystitis, perfect. That's a bladder infection. What if someone has an infection within their kidneys? What do we call that? It's hard to spell. Yep, polynephritis. You might hear it called nephritis. You might hear it called polynephritis. And what do we think about that? That patient's sicker. We're going to be giving them antibiotics. We're going to be giving them IV fluids. We're going to be watching their temperature. We're going to be looking at their white blood cell count because they have an infection within their liver itself. Perfect. So let me bring up the PowerPoint that we talked about yesterday. I'm just trying to help us review and think about what did we learn, and hopefully we were paying attention. It looks like everybody was, so that's amazing. Okay, so here's 3 parts of our system. Let me share this and start the slideshow so you guys can see it. Slideshow from the beginning. All right, can you guys see that okay?
Yes.
Yes, okay. So we talked about UTIs, 3 parts of the system. The main bacteria that causes UTIs is called E. coli. Untreated UTIs can lead to an infection within the kidneys and urosepsis. There's a word that we need to recognize what it means. It started as a urine infection and now it's traveled and the patients are actually septic and the bacteria has entered their bloodstream. Here's our people that are at risk for UTIs. We just talked about all these. One other thing to remember that you might see in a question, select all that apply. Wearing synthetic underwear or polyester underwear or pantyhose puts you higher risk. So we're going to encourage the patient to wear cotton. And then obviously keeping the area wet and moist is certainly not going to help prevent UTIs. We want to get your wet bathing suit off, stay dry, keep your female little baby dry, whatever little child that might be incontinent, whatever it is, keep them dry, because warm, moist, wet areas is where bacteria likes to grow. There's our signs and symptoms. We all recognize what these words are now and what they mean. There's our signs and symptoms in the elderly, a little bit different than the average adult or child patient. Here's our nursing care. This is important. Things that we would do if a patient has a UTI. The fluid intake increases up to 3 liters. We're going to give antibiotics, have them urinate, even if they don't feel like they need to go, just empty their bladder so that the bacteria is not sitting there. Encourage them to shower. We're not going to want them to get in the bathtub. No catheters, wipe from front to back, avoid feminine products, toilet paper with perfume, and all these things that we talked about yesterday. Here's polynephritis. What happens? Inflammation and infection. Remember, there's that itis word again. So what do we expect to be high? Their white blood cell count, E. coli is usually the cause for this. Not always, but frequently is the cause. And then again, your kidney function is affected by this. Your kidney function is not always necessarily affected with the UTI. It's in the urinary tract itself, but this is within the kidneys themselves. Here's our risk factors for polynephritis, and we talked about this yesterday. Here's our treatment. IV fluids, IV antibiotics, rest if the patient needs. If the kidney stone is causing a blockage and causing this infection to enter into their kidney itself, take out the stone. The antibiotics could be 14 days of a PO antibiotic, or it could be IV antibiotics in the hospital. So that's kind of in a nutshell what we talked about yesterday. The next topic for renal is kidney stones. So the name for kidney stones is renal calculi. What does that even mean? It just means kidney, and the calculi word means stone. So if you see it written in somebody's chart, renal calculi, you see it written urolithiasis, or might say nephrolithiasis. Cholelithiasis, hint is on the test tomorrow. That means gallstones. I hope everybody gets that right. So lithiasis means stone. So if it says uro, that means it's in the urinary tract itself. If it says nephrolithiasis, it's in the kidney itself. There are ureterolithiasis with an O at the end. That means it's a stone in the ureter. So depending on where it's located is the first part of the word. Chole meaning gallbladder, and then uro meaning urinary system, nephro meaning kidney. So kidney stones, what do we know about them? More likely to happen in men. We're not really 100% sure why, but men are more likely to get kidney stones. One thing I will tell you about a kidney stone, always remember it's severe pain most of the time, and we're going to treat that pain with IV. Usually opioids, Tylenol does not usually cut it for these patients. If you've ever had a kidney stone, you know exactly what I mean. People will describe it almost as bad as being in labor. If it's a female patient and she's been in labor and knows what it feels like. So that pain is usually 10 out of 10, 8 out of 10. It's pretty severe pain. Again, how do we diagnose it? Can we diagnose a large enough stone with just a simple KUB x-ray? Kidneys, ureter, and bladder? Yes, we can. We can see it on a regular x-ray. Now, if it's smaller, go back to those diagnostic tests that we talked about at the beginning, and it might be an IV pyelogram where we inject dye and then we see the stone. It may be an ultrasound of the kidneys if the stone is in the kidney. So not one single test tells us everything. Most of the time, a stone that's large and the patient is in severe pain, we can typically see it with an x-ray, but not always. So here's our treatment. If the patient has a stone, we're going to treat the pain. We're always going to increase fluid. So that would mean drinking more fluids and then obviously giving them IV fluids to help force out that stone that the patient has. We're going to strain their urine. There's actually, I think I might have a picture. I don't know if I have it in here. Maybe I don't. So there's a little hat, I guess you wouldn't call it. Almost looks like a urinary hat, or almost like a filter or a funnel that you would push, drain their urine into. Patient maybe voids into the hat in the toilet. Take that urine and dump it into this filter, this funnel, and there's at the bottom of the funnel, is like a real tiny mesh graft, and we'll collect any stones that the patient has. And that's what we do. What we want to know is, did the stone pass? How are we going to know that? If the patient pees into the toilet, how are we going to see it? If it's small enough, we're not even going to be able to, it could be flushed down the toilet and we don't even know if it passed. So we use this little funnel type device to strain the urine, and basically the patient doesn't pee into it. The patient goes in the urinal, we take the urine from the urinal and dump it into it, and then we can see when the stone has passed. Most patients are able to pass a stone, which means that it's expelled. And again, if it's a female patient, it's just peed out their urethra when they pee. Male patient, same exact thing. When they pee, it comes out in their urine stream from their penis. And again, if it's small, we're going to need that little graft to kind of collect it. Once that stone passes, the patient feels much, much better. The problem with the pain, the reason why they have so much pain, is there's a stone that's located somewhere that's preventing blood getting through that urethra or that ureter, preventing urine flow from going through there, causing some areas of ischemia around that ureter, wherever it might be. And large enough stones actually sometimes we have to go in and remove that stone. Our risk for the patient, if we don't get that stone out, is their urethra is blocked, or their one ureter is blocked, or it's blocking the opening from the bladder, draining into the urethra. And so you have to picture that if the stone's large enough, it can create obvious issues with sepsis, urine infections, urine flow not coming out. And when that stone is passing and moving, the patient many times has pretty significant pain until they fully pass that stone out. Most of the time, people can expel the stone, but again, it depends on the size and location and composition, how big it is. And I'll show you some pictures here of what some kidney stones look like. So here's our risk factors for renal calculi. You have to recognize what that word even means. Higher incidence in males. People that have recurrent UTIs, meaning that they have frequent urine tract infections. So it might be I had an infection in March, and then I had another one in June, and then patients back in the urologist office in the fall with another infection. And so frequent UTIs make people more likely to develop stones. People that eat a lot of purines in their diet, and we're going to go over in a minute what purines even are, those people have issues with gout, and they also have issues with kidney stone. A lot of times the picture of the patient with frequent kidney stones, they also have issues with gout, and we'll go over what gout is in a minute, but it's a type of arthritis. And many times that can be diet controlled, and we'll talk about what to tell these people to avoid. High alkalinity or acidity of urine, what does that mean? Well, what's our normal urine pH? Somewhere between 4 to 8. Our middle number is about 6. That's about what we normally want our urine pH level to be. So if we had a patient void and we put a pH strip into the urine, we would get somewhere around 5 or 6 normally. Remember, our GI pH is 1 to 4. Urine is usually 4 to 8. So I always remember it's somewhere right around 6. So too high or too low of urine pH can make a stone develop. So again, basic kidney function, if our kidneys are working, most of the time our urine is kind of in the right range. Urinary stasis, what does that mean? That's the patient that has urine retention, or urine is sitting in their bladder and they're not emptying their bladder like it should be. Frequent infection can develop, but also these stones can develop. One key thing for a risk factor for older people, being dehydrated. So the more that we keep them hydrated and fluid flowing into their body, fluid flowing through their kidneys, the less likely they are to develop a UTI. So there it is. Decrease in fluid intake or problems with dehydration are always going to make a patient higher risk for kidney stones, renal calculi. And then metabolic orders such as diabetes. So you got a picture of a patient here that one has diabetes, maybe is a male patient, maybe doesn't drink enough fluid like they should, maybe has had a recent urinary tract infection, and then all of a sudden they have flank pain on their right side. You should be thinking kidney stone. There's a lot of risk factors for that patient that we just described. So here's your risk factors: male patients, frequent UTIs, diet that has a lot of purines, and again, we'll go over what that even means in a minute. Patient that has urinary retention. So there might be your male patient that has an enlarged prostate. Now they've got two problems. the problem's peeing and voiding, and now they developed a kidney stone as well. Your patient that's not getting up and moving around, higher risk for a kidney stone because obviously there's no mobilization of fluid. There's less voiding of fluid. There's less intake. The patient's bedridden. So that could be somebody who knows, spinal cord injury patient, or a patient that had a recent hip fracture that's not getting up and moving. So a lot of the fluid is not circulating through the body system like it should. Particularly your patient that's dehydrated, high risk for renal calculi, high risk for stones, and then your diabetic patient. So this is just showing you a picture of here's a stone located within the kidney itself, and that would be called nephrolithiasis. That means it's within the kidneys. If I have a stone here in the ureter, that would be called uretero, has an O at the end of the word, lithiasis. That means that the stone is located in the ureter. You might see a term in a patient's chart that just says urolithiasis. All that really means it's somewhere in the urinary tract. It could be the urethra, could be in the bladder. So again, just recognizing you're going to see these terms in patient's chart if they have a stone, and it just basically tells where the stone was located. This looks like a pretty good sized stone. You can imagine that blocking blood flow to that section of the kidney can actually be a really bad thing for that patient, right? They're going to have a lot of pain, and we're going to actually be cutting off circulation, and they have ischemia to that area of the kidney. So what are we going to want to do? Increase fluids, get the patient up and move them around. Even though they're in pain, we want them to get up and move around. Why would we want a patient to get up and move around? Put it in the chat if they have a stone. Don't pick bed rest for that patient. Pick that you want to get them up. Why would you think we'd want to move them around? Somebody type in the chat why you think you have this patient. One of your answers would be have the patient ambulate in the hallway. What are we trying to get them to do? Move the stone. We're trying to get them to pass that stone, because if the stone stays here in the ureter and we have the patient just laying in bed for the next 3 days, that's not really going to do a whole lot for us, right? Sure, it might pass on its own, but getting the patient up and moving them around, and again, they're in pain. Remember, they're not going to want to move around. But you have to tell them, okay, try to get up and walk, and that might help pass that stone that you have just by gravity alone. Okay, maybe when you pee the next time, that force or that stream of urine coming through here might be enough to help pass that stone into the bladder, and now you can expel it. So yes, you want them to get up and move around. The symptoms that the patient has are going to be based off of where the stone is. There's a type of pain if the patient has a stone, usually within their kidneys or their ureter, called renal colic. Typically begins in the abdomen and often radiates back to the back, right where that costovertebral angle is. That's right below your 12th rib in the back. This is called renal colic. This could be because the stone is in the ureter, could be because the stone is in the kidneys, but this is the type of pain that the patient comes in and describes to you. Usually sharp pain, they'll tell you maybe it starts in my stomach, but I feel it going through to my back, or I feel it on my right or left side, depending on where that stone is located. Sometimes they have pain that travels down into their groin, because maybe the stone is actually moving down the ureter, and now they have groin pain. You can see where their groin is related to where that stone might be. So this is your typical presentation of the patient with kidney stones. Abdominal pain might be where it starts. It might be flank pain on one side or the other, depending on where the stone is located. It may be groin pain, where they might tell you I have a sharp pain that's going into my groin because the stone has started to move a little bit. The other thing that they typically see is blood in their urine. That's hematuria. Because as the stone is trying to move through, it's creating trauma in that urinary system as it's moving through into the bladder and out through the urethra. So you will definitely, almost always, the patient will tell you, I had some blood in my urine yesterday or today or 2 days ago, and I started with this abdominal pain. That's usually your signs and symptoms, your key things that you're looking for this patient. So understand what renal colic means. It's typically the pain that the patient gets when they have a kidney stone. And how would you describe that pain? Typically begins in the stomach, may radiate to the back, right underneath that last rib in the back, or it might be on their flank area or into their groin. So again, don't get caught up in what's the stone made up of, and there's lots of different things that can create kidney stones. It could be high phosphorus, it could be high calcium, it could be too many purines in the diet. There's many different types of kidney stones, and when that kidney stone gets passed, and this might be their first time or it may be their 10th time, sometimes the doctors will say strain the urine for stones, and they might even decide to send that stone to the lab, and this would be an order by the doctor. And they would basically evaluate what kind of stones is this patient developing, and that would kind of guide us. How do we change the diet for this patient? One thing to remember for somebody with kidney stones, pain management, pain management, pain management. It's going to be opioid, it's going to be IV pain medications if we can give them to the patient. Now, we LPNs can't push IV medications, but you could pick anticipate the RN administering morphine or Dilaudid for this patient. We've seen it on an x-ray. We know they have a stone. We know what their symptoms are. We don't always have to take them to surgery. It's a little different than the appendix. So we want to treat their pain. We see it. We know what it is. We got to treat their pain and get rid of their pain for them so they can get up and move around and try to pass this stone. So again, we might need IV dye tests in order to see it. If we didn't see it on the x-ray, one thing to remember, a couple things to remember with kidney stones, fluids and pain management. That's the two things. And then obviously monitor for the stone pass. Here's the risk factors. We just talked about it. I'm not going to read through them all again. Here's some of the foods that put people higher risk for developing kidney stones. Tea, black tea, spinach. This is if they have developed an oxalate kidney stone, and all that really is what's the makeup of the stone itself. Purines. Let me go over what purines are. So here's your high oxalate foods, things that can, and if somebody has a kidney stone, these are the things that they would tell them to avoid so you don't develop another one. Or they would ask them, tell me what your diet's like. Well, I eat a lot of this and this and this. Well, they're the things that are high risk. So again, these are things that have purines in them, or I'm trying to get rid of this bar that's on here. Things that we would recommend for this patient not to eat. So here's the most important things not to eat, group 3. So you can pick these things up here, avoid these things down here. So this is the same exact teaching we would do for the patient with gout. Very similar, and there's a couple slides on gout in here, and what gout is basically the arthritis that develops because uric acid builds up. People can get kidney stones when their uric acid level goes too high. And we'll talk about what normal is. So just for now, look at this slide. Tell me where this darn thing. Okay, so avoid these foods: nuts, peanuts, sweet beans, fish, gravies, internal organs like liver, yeast. Here's some of the foods. And it's hard for us to remember all of them, but what you're trying to tell the patient is avoid foods that are high in purines. Purines are basically like, I describe what purines are. They're more like byproducts, I guess, that are in foods when they make them. And there's certain foods that are higher in purines. It's P-U-R-I-N-E. So they're the foods that they should avoid and not eat. So the patient with kidney stones, many times the first stone, the doctor would just say maybe it's because they were dehydrated, or maybe it's because they're diabetic. They just had a second stone 6 months later. They're looking into what kind of diet does this patient now on. What things can we tell them to avoid? Certain things will trigger the development of a kidney stone in your body. So those are the things, let me go back to it, that we would tell the patient. There's another slide. Okay, so here's some of the things that we would tell the patient not to eat. Is it okay for them to eat cheese, eggs, butter, margarine? Sure, that's okay. Use in moderation, these things in the middle. One other thing, alcohol is a big trigger. Beer in particular is a trigger for kidney stones. So drinking a lot of beer, because there's purines in beer. These things you can eat, this group in the middle, but use in moderation, and then avoid these things down here because you're more likely to develop or cause your body to develop a kidney stone. So go back. And again, depending on the type of stone it is. If it's a stone that is from your diet high in purines, it would be more like a calcium stone, and they would be able to evaluate this in the lab and say, hey, this stone is made up of this. This is what the patient is prone to. Okay, the patient has a history of diabetes, and they eat a lot of the foods that, we need to teach them how to avoid those foods. One other key thing with people with kidney stones, many times the stone is triggered because the patient has been dehydrated. So we ask them, what's your intake been like for the last couple of days? Well, it's hot, it's the summertime, I've been outside at the beach. What have you been drinking? Well, I've been drinking beer for the last 2 days, or I haven't had a lot of water to drink. And many times that's the trigger that makes that stone develop, and the patient develops a kidney stone and they have the pain. So what are we going to tell them at that point? Well, keep yourself hydrated. And here's some things that you might want to not take in your diet as much. Again, there's some things in moderation. We can't tell everybody don't eat this, this, and this, because people don't always abide by what we say. But what we can tell them is certain things that create those purines, and the high purine content, why you get a stone, is your uric acid level goes up. And uric acid level, when it's high, causes crystals to form, and these crystals can develop into stones. So that's the key. That's the easiest way to try to describe it. Uric acid level goes up, crystals form, stones form. People that have gout, uric acid level goes up, crystals form, and they have symptoms of gout. And we'll talk about what those symptoms are. So again, just put these things together. People prone to gout are also prone to kidney stones. And many times it's that older male, middle-aged male patient, I should say. Maybe it's a patient that's dehydrated. Maybe it's a patient that hasn't been moving around and mobilizing their urine, and so it's just sitting in their bladder or sitting in their kidneys and not voiding like they should be. It could be the male patient that has problems with the prostate, and now they're retaining urine, and then crystals are more likely to form. So hopefully you're getting a picture of the person that is more likely or has a higher risk for developing kidney stones, and they're called renal calculi. Again, metabolic disorders such as diabetes. All this really does just describe that the diabetic patient is more prone to kidney stones, more prone to gout, more prone to hypertension, more prone to kidney disease, more prone to a lot of different things. So diabetes, we haven't went over that yet, but you'll see that diabetes is a risk factor for many things from the people that we're taking care of. It started with diabetes, and now other problems have developed. And this just kind of explains why diabetic patients are more risk. So here's some things that we want to avoid. There's kind of a chart that helps guide us and teach them things that they can eat in moderation, things that they should avoid. Here's signs and symptoms. We talked about what renal colic is and how you would describe it, and it's the pain that's associated with kidney stones. The pain can become worse as stone passes through the ureter, because go back to what our picture of the ureter is. It's a pretty thin tube draining from our bladder, draining from our kidneys down into our bladder. And then the urethra is the opening from the bladder to the outside. So flank pain is many times one of the symptoms that they have. It might radiate to their abdomen, or if it's a male patient, down to the scrotum or into the groin area. And they have hematuria. They might have to void frequently, and it might only be small amounts because we can't get past the stone itself, and they a lot of times have dysuria, like difficulty or painful urination. Here's some objective things. So these are things that the patient would tell you, subjective, right? Objective things are the patient's sweaty. They might have nausea and vomiting. Their heart rate usually goes up because they're in pain. Their respiratory rate usually goes up because they're in pain. They may not have any urine output, and here's the key. This isn't your dialysis patient where we say, okay, it's okay, they're not making urine. If you normally were making urine yesterday, and you started noticing some blood in your urine, and now you come into the ER with severe flank pain, and we see you have a kidney stone, you not making urine is a huge deal, because now what does that mean? The patient's not passing any urine. There's some kind of obstruction going on from the stone. And that can be a medical emergency, meaning the kidneys are making urine, but it has nowhere to go because that stone is so large that has completely blocked the urethra, blocked the bladder opening into the urethra, is lodged in the ureter above, right below the kidney. Go back to our picture of the urinary tract system. And if we have a stone that's large enough and the patient's not peeing, we have a really big problem. It's a medical issue because total obstruction of urine has happened from this stone. So again, look at the patient, see how much they're avoiding. Are they still peeing? How bad is their peeing? Let's get an ultrasound or at least an x-ray to see where that stone is located. How big is it? Do we think it's even going to pass on its own? Okay, if you think it's small enough to pass, IV fluids, drink fluids, whatever access you have, get the patient up, walk them around, treat their pain until that stone passes. And then they're now able to pee again. If it's large enough that it can't pass, sometimes we have to go in and do like lithotripsy, which is the shock waves, and break it up. Sometimes we have to do that IV pyelogram and flush out the ureter and the urethra with fluids to try to get that stone to dislodge. Sometimes, if it's large enough, patients could potentially have to have their kidney removed, and that's called an nephrectomy if we can't get that stone to move down into the urinary system. So stones can be a minor thing, and people pass them at home. And people that have kidney stones frequently know that a stone is developing and start getting those symptoms, and they know to keep drinking, getting up and moving around. Other patients, it comes on suddenly and they have never had a stone before, and it can be a medical emergency for that patient. Here's some tests that we would do to diagnose a kidney stone. There's your KUB, that's just a general ultrasound looking at the kidneys, the ureters, and the bladders. And the bladder, I only have one bladder. So again, this is an x-ray of the abdomen, not a whole lot of preparation for the patient. They don't need to be NPO, there's no preparation afterwards. The only thing we have to worry about is the patient pregnant because they're going to be exposed to radiation. But basic x-ray is where we start. And if we can see the stone on there and see how big it is, the doctor can determine if they think it's going to pass, or no, we have to do further intervention because the stone is lodged and not going to be able to be passed by the patient. The patient might have IV pyelogram. If you see something with an intravenous contrast, right away in your head, you should be thinking, okay, this patient's getting die. So what do I want to know? I'll do the shellfish or iodine. I want to obviously have the patient increase fluids. I want to know if the patient's on metformin. Everything should start clicking in your head now, like things that you're going to need to recognize if the patient's getting die. If the patient's getting die, I'm going to monitor them for signs of an allergic reaction. So do they have hives? That's called urticaria. Do they have itching? Do they have trouble breathing? All of this should be stuff we should already know at this point. Okay, or they might get a CAT scan and an MRI. And sometimes patients get 2 or 3 of these tests if they're trying to locate the stone. Sometimes the KUB is enough and we see it. So again, it just depends on where the stone is. What's a cystoscopy? That's where we go into the penis or the urethra of the female patient, and we put a tube in with a light at the end, and we're looking in, it's a scope, and we're looking into the bladder to see if we can see the stone. Can we potentially, with certain devices the doctor used, can we grab that stone and pull it out if it's small enough? Yes. So it just depends on where the stone is, how big it is, how much of an obstruction there is for the doctor to decide, okay, what are the interventions that we need for this stone? Because there's not one test, so there's not one intervention that works for everybody. So here's some things that we would have to do for this patient. Pain management, opioids are what we're going to use, particularly in the first 24 hours of the stone. And then again, when the stone is passing or moving, patients will tell you their pain is worse. I've had patients show up in the ER, they're sweaty, they're pale, they have pain on their left side, they have blood in their urine. We're immediately thinking kidney stone. IV fluids, try to flush that through, get an ultrasound, get a CAT scan, figure out where the stone is. If it's completely obstructing their kidney, that's a medical emergency. We got to do some kind of treatment to help that stone move through and reopen that urethra and allow the kidney to drain, right? Because the kidney can't just stay non-functional. With the opioids, remember, if you pick that you're going to give them something like this for pain, monitor respiration. What's our biggest complication? Put it in the chat for opioid medication. What's our biggest risk thing that we have to think about? Put it in the chat and let me know what you think about opioids, because this is going to be your answer on NCLEX. If the patient got morphine, or the patient got Percocet, or the patient got Dilaudid, IV, what's our biggest issue? Breathing, breathing, breathing. Keep that in your head, breathing. Monitor the respirations. If your patient with kidney pain and a kidney stone already has a respiratory rate of 10, are we going to give them opioids? No, we're not, because we're only going to make their breathing worse. What's our antidote? What would we pick to give the patient if they got too much morphine, or if they had a prescription for Percocet, or they had kidney pain at home and somebody in their family had Percocet, and I took 6 of them today because my pain's so bad. Okay, now the patient's barely breathing. What are we then going to give them for opioid overdose or opioid, too much opioids? Naloxone. Yep, Narcan. The word you're going to see for Narcan on NCLEX will say naloxone. So that's your opioid antidote. What does that even mean? That means if they have too much morphine, doesn't matter what the story is, whatever the patient's problem is, they have too much morphine and the respiratory rate is 6, give them Narcan, give them naloxone, because that's going to reverse the opioids that are in the system. So here's your management for the renal calculi patient. IV fluids, treat their pain. First 24 hours, usually opioids. Can we give them NSAIDs? Yes, because it decreases the inflammation. Now, if they're severely bleeding from the kidney stone, and I'm talking bright red blood, we probably would hold off on the NSAIDs and pick something else. But Tylenol is not going to cut it for these patients. It's not going to be enough. If we give them the opioids, monitor the respirations. Antibiotics are needed. Why? Because this kidney stone certainly can lead to a urinary tract infection. They might already have a urinary tract infection that caused the kidney stone, so we're going to give them antibiotics. And then there's different types of sound waves, or lithotripsy is what we call it, where we use shock waves to break up the stone. Now we can do that from the outside, or we can do it from inserting an IV and send the shock waves that way through a pyelogram. Most of the time it's done through the outside, more like an ultrasound directed right at that stone. And we use the ultrasound and we can see the stone, and we send shock waves through the patient's skin into the stone, and it breaks it up. So the patient's sedated, they're not fully safe, but after we do that, remember, it's okay. They're going to expect some bruising and some blood in your urine from us breaking up that stone. That would be acceptable. That would be what we would expect to happen. Now that we know, here's our key thing. If our patient had in our story some kind of lithotripsy or some kind of shock waves that were used to break up that stone, what are we going to do afterwards? It's not going to change. We're going to give them IV fluids, or at least tell them to drink a lot of extra fluids. And now we're going to strain their urine just like we normally would be doing, because that's what we've done. We've broken up those stones, and now we want to see if they come out. So it makes sense that after we use sound waves or shock therapy, and again, there's different types that are out there. It doesn't matter. We don't need to study the types because we're not going to be doing that. But if your patient goes down for lithotripsy for a kidney stone and comes back to you from this test, or comes back to your facility and you know they had this procedure done, you're going to be thinking, I want to strain their urine. I want to see if they passed the stone. I want to know that that stone came out. And the patient, or you ask the patient, have you passed anything? And many times the patient will say yes. Or you're collecting it in that little filter device, and you can see the stone come out. So shock therapy is a lot of times what's used, so we don't have to invasively do surgery on this patient, right? And there's issues with doing surgery. Here's some types of surgical procedures if we can't do shock wave therapy. And again, you're not the surgeon, you're not going to be doing these, but these are just names of some of the different types of surgery that we might go in and do. And ureteroscopy means inserting a tube with a scope, looking up into the ureters and actually grabbing and removing the stone that's there. So it depends, again, where the stone is located. How big is it? Most people, remember what we said at the beginning, can pass the stone on their own. Almost the majority of people do that. Sometimes we have to do these other interventions if the stone is not passing on its own. So here's some things that we would, again, be encouraging people to not have in their diet. And don't get all caught up on limiting, AMPG. That's a word that we rarely will see. The things that you're going to see on NCLEX is a low purine diet. Decreases your risk for gout if you have a risk factor for that. Decreases your likelihood to develop kidney stones if you're constantly developing them. And there's certain medications that we tell these patients to take as well, and we'll talk about them in a minute. So there's your patient with renal colic. You can see how the pain is in the back flank area, one side or the other. It doesn't always have to be the left side or the right side, depends on where the stone is. Pain coming around that side into the groin. That's typical picture of what we describe, and it's called renal colic. It's kidney pain, basically. Lots of times it's a sharp pain. It comes and goes. It gets worse as the stone moves, and the patient will tell you, I have pain on my left side. I'm sweaty. I'm pale. It might be throwing up. The pain is so bad, they get nauseous. They vomit. They have pain going into the groin. So again, these words are here just to say, hey, depending on where the stone is located, if it's nephro, it's within the kidneys. Uretero is how you say that, it's within the ureter. Uro just means anywhere in the urinary system. Cystolithiasis means it's a stone that was in the bladder. And this is just a patient with kidney stone pain. It has it located right there in the renal pelvis, the biggest section of the kidney, and now it has pain in his back, and I have pain going into the groin. Men more than women, doesn't mean women can't have kidney stones, men are more likely. And again, this is just going over some different tests, different diagnostic things that we can use for the patient. Shock waves, ureteroscopy going in with a scope into the ureter and pulling out that stone if the patient can't pass it. And then here's some of our diagnostic tests. There's some pictures of kidney stones. You can see how some are really small. The patient can pass them. You can see this really big one right here. And sometimes the doctor will ask if the patient passes it. How big is it? How many millimeters is it? This one here probably isn't as big enough that the patient may not be able to pass that. Just depends. Just depends on how much they're drinking and can it flow through the urinary system. Are they able to pass that out? This might be a stone right here, one of these big ones that needs a shock wave sent to it, and it breaks it up into smaller stones, and then the patient can pass it. All right, let me see. All right, before we keep going, let's take a break, and we'll come back and we'll talk about some things in their diet that we can change. How many more slides is there on this one? Yeah. Okay, so let's take a break. There's several more slides. We'll talk about gout a little bit, and some things in the diet that we would change for this.